Hey everyone, welcome back to Medibits with Dr. Shraddha, where we turn tough pathology into easy visual learning. Today we are diving into one of the oldest and deadliest rivalries in medical history, man versus mosquito. Yes, it's time to code malaria, a high yield topic both for exams and for real world medicine, especially in tropical countries like India. In this video, we will break down story of malaria from mosquito bite to fever spikes and how to diagnose and manage it all in one rapid visual recap. So grab your notes and let's beat the mosquito at its own game. Okay team, by the end of this class, you will have malaria sorted out like a story. We will know who causes it and how it spreads, understand its life cycle so it's easy to remember the fever pattern and connect it with what happens in the body. Then we will quickly go over main symptoms and how to diagnose it on smear and treatment basics. And yes, I will highlight must know NEET PG facts so you can score easy marks on this topic. Okay students, malaria is caused by four major species of Plasmodium. Plasmodium vivax, which is most common in India. Plasmodium falciparum, which is most dangerous, causing severe complications like cerebral malaria and renal failure. Plasmodium malariae, which causes cotton fever, that is every 72 hours. Plasmodium ovale, which is rare but clinically resembles vivax. Vector is female Anopheles mosquito, which acts as a definitive host, and humans are the intermediate host. Malaria thrives in warm, humid climates. That is why outbreaks are common in monsoon season. So students, understanding the life cycle of Plasmodium is very important. There are two hosts. First is human host and second is mosquito host. First, we will briefly understand the stages inside the human host. An infected mosquito injects sporozoites into the human bloodstream while feeding. These sporozoites are infective form to humans. Now comes the liver stage. Sporozoites travel via blood to liver. They enter hepatocytes and multiply, forming schizones. Each schizone ruptures to release thousands of merozoites. These merozoites then enter in bloodstream. Remember students, in Plasmodium vivax and Plasmodium ovale, some sporozoites become dormant hypnozoites causing relapse later. Now comes the blood stage. Merozoites invade RBCs. Inside RBCs, they develop through various stages. First is ring form, that is trophozoite. Then comes mature trophozoite. Then comes schizoned, multinucleated stage, after which RBC ruptures releasing more merozoites to infect new RBCs. This rupture of RBCs causes fever spikes, the paroxysms of malaria. Now comes gametogony, that is, some parasites in RBCs develop into gametocytes, male and female. These are infective forms to mosquitoes. Now we will discuss mosquito stage. When a mosquito bites an infected person, it ingests these gametocytes. Inside mosquito gut, these gametocytes fuse to form a zygote, which eventually forms ookinete. This ookinete penetrates the gut wall of mosquito and forms oocyst. Inside this oocyst, many sporozoites develop. These sporozoites then migrate to the mosquito's salivary glands and are ready to infect the next human. Alright guys, let's break this down step by step like a story what is actually happening inside human body when someone gets malaria. First is parasite multiplication, which causes RBC lysis leading to hemolysis. So once Plasmodium parasite enters the bloodstream, it goes straight for RBCs. It gets inside, multiplies, and when it is done, it bursts the RBCs open to release new merozoites. This is called hemolysis, that is destruction of RBCs. And every time RBCs burst, more parasites are released which can infect more cells. This explains why fever comes in intermittent spikes. It's synchronized with this RBC rupture. Second is release of pyrogens which causes fever spikes. So when these RBCs burst, they release parasite waste products and pyrogens, which are fever causing substances. These stimulate hypothalamus, which is body's thermostat, leading to high fever with chills and rigors. So those malarial paroxysms, high fever, chills and sweating are directly linked to RBC destruction. Third is splenic hyperplasia leading to splenomegaly. Now spleen is like body's filter. It works overtime to clear out all those destroyed RBCs and parasites from circulation. Over time, this spleen becomes enlarged, leading to splenomegaly. This is why in endemic areas, many patients present with a palpable spleen. Next is hemoglobin breakdown, leading to jaundice anemia. When RBCs rupture, hemoglobin is released. Our body breaks it down into bilirubin, which leads to jaundice, leading to yellowing of eye and skin. Also because so many RBCs are being destroyed and not replaced quickly enough, the patient develops anemia. So fatigue, pallor and jaundice in a malaria patient are not random. They are direct consequences of this hemolysis. In short, parasite destroys RBCs, immune system and spleen react, body's response causes fever, anemia and organ changes. That is why malaria is not just a fever, it's a hemolytic disease with systemic effects. Alright team, when you are on OPD duty or in your postings, you will probably meet a patient like this very early on. So what is the typical story? Step 1. High grade fever with chills and rigors. Patient comes shivering like crazy, wrapped in blankets and then suddenly gets this spike of high fever. That classic I am freezing, I am burning combo is a big malaria clue. Step 2. Headache, malaise and body ache. Basically, they will feel miserable. They will complain, Doctor, I feel tired, weak and everything hurts. It's like flu but worse. Step 3. Pallor and mild jaundice. Why? Because this parasite loves breaking red blood cells. That hemolysis gives you pallor and a yellow tinge in the eyes. Step 4. Splenomegaly and sometimes hepatomegaly. Yes, that poor spleen is on overdrive, filtering all those destroyed RBCs. So it gets big and sometimes liver joins this party too. Now an important part, fever patterns, which is high yield for exams and vivas. Tertian pattern is fever every 48 hours seen in vivax and oval. Quartan pattern is fever every 72 hours seen in malaria. Irregular fever is no fixed pattern seen in falciparum. So if someone walks into clinic with fever spikes, chills and looks pale or jaundiced, your brain should yell, think malaria. And remember, early recognition saves lives. So next time you are in postings and someone says, Doctor, I have had fever for 2 days with chills, you will know exactly what to look for. Alright students, let's talk about how we actually diagnose malaria. The gold standard is peripheral blood smear. We do two types of smears. First is thick smear and second one is thin smear. So thick smear is like casting a wide net in the ocean. It helps us detect parasites easily because there is more blood and higher chance of finding them. In thin smear, we zoom in to identify specific species of the parasite. Super important for deciding treatment. Now this picture shows thick smear. You can see background of so many RBCs and inside these RBCs you can see ring forms. So these are rings of falciparum in a thick blood smear. Now this is a picture of thin blood smear. You can see less number of RBCs and inside these RBCs there are ring forms. So these are rings of Plasmodium falciparum in a thin blood smear. In this picture you can see banana shaped gametocytes of falciparum. So, high proportion of infected RBCs, including doubly parasitized cells, is characteristic of Plasmodium falciparum. In this picture, you can see Plasmodium vivax trophozoite. You can see this amoeboid shaped structure. So, this is vivax trophozoite with Schaffner's dots. So blood smear shows both detection and identification of the parasite. Next are rapid diagnostic tests or RDTs. These are fast, field friendly and don't need a full lab setup. These are detecting parasite antigens, little molecules from the malaria parasite, and the two biggies here are HRP2 and PLDH. HRP2 is specific for Plasmodium falciparum and PLDH is more of a general parasite detector. Now let's say you are doing a blood test, the CBC, and you will probably see anemia because those parasites are popping red blood cells like bubble wrap, and thrombocytopenia, which means low platelets. Yes, that's why some malaria patients bruise easily or bleed more. Then your LFTs, liver function test, might show mild elevation. So liver is saying, hey, I am working overtime here. And last but not least, always rule out other causes of fever. Malaria might be a top suspect, but don't forget typhoid, dengue, or even the common viral fevers trying to sneak in. Okay team, now that we have mastered the clinical features, let's go one level deeper into histopathology and organ involvement in malaria. This part is like seeing a battle between the parasite and our body under the microscope. First is spleen, which is like the security checkpoint of your blood. In malaria, it gets massively congested because it's busy filtering all those infected RBCs. The red pulp is congested, packed with parasitized RBCs. Macrophages proliferate like crazy to clean up the mess. You will also see malarial pigment called hemozoin, like the parasite's trash left behind. In chronic malaria, the spleen can get fibrotic, becoming firm and heavy. The liver also pitches in. It becomes moderately enlarged, which causes hepatomegaly. Kupffer cells, which are liver's resident macrophages, become hyperactive, gobbling up infected RBCs. Pigment deposits give the tissue brownish tint. Necrosis is minimal. Architecture usually remains preserved. So now comes the big boss level, the brain, which causes cerebral malaria. Parasitized RBCs sequester in cerebral capillaries. So in this picture, you can see sequestration of malaria parasites in cerebral microvessels. Appreciate the parasites in the erythrocytes within the blood cells. You will find vascular congestion, ring hemorrhages, and brain edema. A classic find is Dirk's granulomas, which is little glial nodules. Neurons suffer injury and petechial hemorrhages can appear. This explains why cerebral malaria presents with seizures, altered sensorium, or coma. Next in line is kidney, which is the cleanup crew. Here we see acute tubular necrosis from hemolysis. Hemoglobin gets dumped into the kidney, which causes pigment nephropathy and that famous black water fever. There is also interstitial edema and congestion. Clinically, this can lead to acute kidney injury, sometimes needing dialysis. So a quick recap for 4 organs and 4 key patterns. Spleen, congestion, pigment, fibrosis. Liver, Kupffer hyperplasia, pigment and preserved structure. Brain, sequestration, hemorrhages, Dirk's granulomas. And kidney, acute tubular necrosis, pigment nephropathy. The common theme here is sequestration of parasitized RBCs and hemolysis. That's the parasite's ultimate game plan. So next time you hear malarial histopathology, don't panic. Just think of these 4 organs and their signature patterns. Alright team, we have talked about the typical presentation of malaria, but what happens when things go really bad? Let's talk about the complications. Scary but important part to recognize early. Malaria is not just fever and chills, especially when it is caused by the boss villain Plasmodium falciparum malaria. I know that long complication list can look scary, so here is a fun way to remember it with this mnemonic: malaria shocks. M stands for metabolic acidosis. Because of tissue hypoxia, lactic acid builds up. Patient may breathe fast, look drowsy, and overall become sick rapidly. A stands for anemia. Because malaria loves bursting RBCs like bubble wrap, the hemoglobin levels crash. You will see pallor, breathlessness, tachycardia. Very common in kids and pregnant women. L stands for lung involvement seen in pulmonary edema or acute respiratory distress syndrome, that is ARDS. So imagine lungs filling with fluid, patient starts struggling to breathe, oxygen drops, and this can happen even after clearing the parasites. So always monitor closely. A stands for altered sensorium seen in cerebral malaria. This is when parasite messes with brain. Patient may have altered sensorium, seizures, or even slip into coma. Think of a patient who was talking normally a few hours ago and now is unresponsive. This is an emergency. R stands for renal failure. Now, acute kidney injury. This is the famous black water fever where massive hemolysis leads to hemoglobin in urine. Urine looks dark, almost like cola, and output drops. Sometimes dialysis may be needed. I stands for irregular sugar seen in hypoglycemia. This one is sneaky. Low blood sugar can mimic worsening malaria. Patient may become confused, drowsy, or even have seizures. Next is A for abnormal coagulation seen in DIC. Malaria can also mess with clotting. So you might see gum bleeding, GI bleed, or bruising. Platelets can drop like crazy. S stands for shock and multi-organ failure. When circulation collapses, we call it algid malaria. Patient may be cold, clammy, hypotensive. This is ICU level emergency. Okay team, buckle up. We are going into battle against malaria and trust me, we have got a solid arsenal. First up, the most valuable player of malarial treatment is artemisinin based combination therapy, that is ACT. This is our first line warrior, fast, effective and ready to smack down Plasmodium falciparum, especially in resistant zones. Think of it like the Avengers but for parasites. Now, if you are in area where vivax is still playing nice, meaning it is chloroquine sensitive, you can use the good old chloroquine. But remember, this works only in specific regions. Don't use it where resistance is a problem or you are basically giving the parasite a spa day. Next up, we have got primaquine. This is one of our sleeper agent, literally. It goes after the sneaky hypnocytes hiding in the liver, especially in Plasmodium vivax and Plasmodium ovale. But warning, always check for G6PD deficiency before using it or things can get messy. Now, if the patient looks super sick, like unconscious, seizures, or really out of it, that's severe falciparum malaria. In that case, we go big with IV artesunate. Straight into the veins, no time to mess around. And finally, don't forget supportive therapy. You have got to manage fluids, bring down the fever with antipyretics, and keep an eye out for any complications. Because saving lives is not just about the medicines, it's the whole package. Alright folks, now that we have diagnosed and treated malaria like pros, let's talk about the real most valuable player, prevention. Because trust me, not getting bitten in the first place is way better than fighting parasites later. Step 1 is vector control. Because if we stop the mosquito, we stop malaria. Think of bed nets, insecticide treated ones, repellents and spraying homes and surroundings. Basically make life hard for the mosquito. Step 2 is early diagnosis and prompt treatment. Catch it early, treat it fast, and yes, you stop the spread. A diagnosed and treated person is less likely to keep feeding the mosquito malaria cycle. Step 3 is chemoprophylaxis for travelers. Planning that dreamy trip to a tropical malaria endemic zone? Don't forget your anti-malarial meds. Pop them before, during, and after travel. It's like giving your immune system a mosquito shield. Step 4 is health education in endemic areas. Knowledge is power. Teaching people how to prevent bites, recognize symptoms, and seek early care saves lives and empowers whole communities. So, yeah, we are not just fighting a bug, we are running a whole public health mission here. Alright guys, a quick rapid fire recap. Plasmodium vivax is the India special. It is the most common type you will see in India. Remember, vivax is very vivacious, keeps coming back if you don't treat it right. Plasmodium falciparum is a dangerous dude. This one causes cerebral malaria, hits the brain, so it is the most severe form. Fever, that's because the parasites all rupture RBCs together like a synchronized dance move. That's why the fever spikes are periodic. On smear, look for ring forms and those banana shaped gametocytes, a total giveaway for falciparum. Primaquine is your relapse preventer. It wipes out dormant liver forms, so don't skip it or malaria will take it up. And finally, untreated falciparum equals to high mortality risk. So remember, diagnose early, treat fast and don't mess with malaria. So students, now we start with NEET PG style MCQs. First MCQ concerns with role of primaquine. Question is, primaquine is given in malaria too. Options are kill schizones in RBCs, B. Prevent drug resistance, C. Eradicate hypnozoites from liver, and D. Prevent mosquito transmission. So here answer is C, that is eradicate hypnozoites from liver. Explanation is primaquine acts on dormant hepatic stages, that is hypnozoites of Plasmodium vivax and Plasmodium ovale to prevent relapse. Remember, chloroquine kills in blood and primaquine kills in liver. So now MCQ 2 consists of the forgotten drug. Question is, a patient with Plasmodium vivax malaria receives ACT and returns with fever 3 weeks later. Which drug was likely omitted? So here ACT means artemisinin based combination therapy. Options are artemether, B. Chloroquine, C. Primaquine, D. Quinine. So the correct answer is C. Primaquine. Remember students, primaquine is equal to relapse prevention of vivax and ovale. So the detailed explanation consists of Plasmodium vivax has liver dormant stage, that is known as hypnozoites. ACT or chloroquine eliminates only the blood stage merozoites, but not the liver stage. Primaquine specifically targets these hypnozoites, thereby preventing relapse weeks or months later. If primaquine is omitted, the liver hypnozoites remain and which cause relapse of malaria. Now the last MCQ, which consists of deadliest form of malaria, spot the clue. Question is, a 32-year-old woman presents with high fever, confusion and seizures. Peripheral smear shows banana-shaped gametocytes. Which complication should be closely monitored? Options are hematuria, cerebral malaria, splenomegaly and mild anemia. So here the correct answer is B, cerebral malaria. Remember students, falciparum plus banana gametocytes plus neuroscience is equal to cerebral malaria. So the detailed explanation consists of banana shaped gametocytes are characteristic of falciparum. Falciparum malaria is notorious for its severe complications because it infects RBCs of all ages and causes them to adhere to vascular endothelium leading to microvascular obstruction. When this occurs in cerebral circulation, it leads to cerebral malaria, which presents with seizures, altered sensorium and coma. It is life-threatening and must be treated aggressively with IV artesunate. Alright champions, this wraps up our topic with malaria. Remember, when it comes to Plasmodium, knowing its life cycle is half the cure. If you found this session helpful, please like, share and subscribe to Medibits with Dr. Shraddha. Till then, stay curious, stay brilliant, stay smart and happy studying.